Greetings. My name is Norman Johansson. I am the chairman of the orthopedic department at Drexel University College of Medicine. I'm here today to introduce Dr. Parviz Kambin, who is professor of orthopedic surgery here at Drexel University College of Medicine. Dr. Kambin has had a long and illustrious career as an innovator in the field of minimally invasive spine surgery. He was an outstanding teacher and mentor to many orthopedic surgeons who are now very well known in the field of spine surgery. Born and raised in Iran, Dr. Kambin graduated from the Tehran University Faculty of Medicine in 1956. He subsequently came to the USA to do his residency at the St. Joseph's Hospital in Paterson, New Jersey, the New Jersey Orthopedic Hospital, and New York University in New York City. He subsequently joined the medical staffs at the University of Pennsylvania, Children's Hospital of Philadelphia, the Graduate Hospital in Philadelphia, and the Allegheny University Health Sciences campus at Medical College of Pennsylvania. He subsequently accepted a full-time position at Drexel University College of Medicine, where he pursued his research and patient care. Kambin's early experimental work with the debulking of the nuclear mass began in 1970. He used a series of cadaveric studies at the University of Pennsylvania and the Graduate Hospital, developing instruments and describing the anatomy and minimally invasive approach to the lateral access to the spinal canal. Dr. Hijikata from Japan had described the minimally invasive removal of nuclear tissue from the intervertebral disc, otherwise called a nucleotomy at that time, in the early 70s. Kambin resisted the idea of nucleotomies. He believed that the extruded herniated disc fragments should be accessed and removed from the canal. He subsequently began his experimental work on the posterolateral access to the herniated lumbar disc. He coined the term minimally invasive spinal surgery and is credited in Dorland's Medical Dictionary for describing the Kambin triangle. He is also credited with 34 U.S. and European patents in the field of minimally invasive spinal surgery. Dr. Kambin has generously supported our profession. He was responsible for initiating the Parviz Kambin, MD, Endowed Chair of Spine Surgery Research in the Orthopedic Department here at Drexel. He is also honored annually with an endowed lecture at the Philadelphia Orthopedic Society. His appearances at this event are treasured as we continue to acknowledge this outstanding pioneer in spine surgery.
Thank you so much, Dr. Johansson.
Dr. Kambin, thank you for agreeing to share with us your experience in the field of minimally invasive spinal surgery. Would you please explain what a disc herniation is?
Sure. Intervertebral disc are acting as a cushion between the vertebra. The intervertebral disc has a nucleus, which is the central part of the disc, and there is a peripheral part of the disc, which is called annulus. In the younger individual, the nucleus is surrounded by very firm fibers of the annulus, and it cannot escape from its surrounding. But as we get older, basically after 35 years of age, the peripheral part of the disc, the annulus, began to show degeneration, shows wear and tear, and the fibers separate from one another, and the nucleus began to migrate through the torn part of the annulus, and at times they come out of the containment of the annulus, and they are able to put pressure on the nerve root and cause sciatic pain. And that is the most common cause of sciatic pain in human being.
Would you please explain the various surgical methods that are used for the treatment of herniated discs?
Yes, most of the patients who are suffering from herniated discs and do have sciatic pain, they respond to non-operative treatment, such as the use of non-narcotic anti-inflammatory medication, certain exercises, and therapy. But there are some who do not respond to the treatment, and we will need surgical management. When the pain persists or patient began to develop numbness or weakness of the limb, they definitely should consult an orthopedic surgeon or neurosurgeon and have further study and plan their future treatment. Two surgeons with the name of Mixture and Barr, they were orthopedic surgeon and neurosurgeon at Massachusetts General Hospital. The first time they described the approach to the herniated disc through a midline incision in the back of the patient. This was published in 1934, and from that point on, this was an accepted procedure to perform a laminectomy, which is lamina is the part of the bone that covers the spinal canal, take part of the bone out and approach the disc and remove the herniated disc. But this procedure was continued for many years up to the present time, and still is useful in certain cases. You have to use this technique to remove the pressure from the nerve root. However, in the recent decades, I would say, there have been several physicians who have tried to find an alternative way of treating the herniated disc. One of those techniques was promoted by Dr. Smith, who used chymopapine, which is a chemical injected into the nucleus or the central part of the disc, and this would destroy the nuclear material, and it was believed that this would take the pressure off the nerve and the sciatic pain would disappear. Following this technique, Dr. Hijikata, an orthopedic surgeon from Japan, developed a mechanical used a very small caliber 2.6 millimeter cannula, and he inserted this into the disc and removed some of the nuclear material from the center of the disc. He felt that this may accomplish the same outcome as Smith had done. Later on, a radiologist with the name of Dr. Onik described a procedure they call nucleotome, which is a mechanical tool that he put inside the disc, and this would move automatically and would cut the nuclear material and would remove it. Later on, laser light was used by many surgeons in Europe and the United States for destruction of the nuclear material. However, later on it was proven that nucleotomy was not adequate for treatment of this herniation, and it is pretty much discarded at this time. I should mention that Professor Adam Schreiber, a friend of mine from the University of Zurich, followed the concept of Dr. Hijikata's technique for nucleotomy. However, he made further advancement by using a larger cannula or tube and larger instruments to remove the nuclear material from the intervertebral disc.
Dr. Kambin, what was your experience with nucleotomy technique for the elimination of pressure on the nerve roots?
I had the privilege to do further studies when I was working at University of Penn Graduate Hospital. We selected a number of patients in 1970s, and I did a open procedure, exposed the herniation and visualized it. Then I put a tube from the side of the patient into the disc and removed the nuclear material from the center of the disc. Unfortunately, at the end of this procedure, I was able to look at the herniation, and through the open procedure that I had done before, and I did not see any change in the size or shape or geometry of the disc herniation by doing nucleotomy. And that was the time I gave up the concept of nucleotomy and began to develop techniques and doing some laboratory work and dissections at the University of Penn to find an alternative method that I could reach the disc fragments inside or outside of the disc and even visualize the content of the spinal canal for removal of the disc herniation which have escaped into the spinal canal.
Was your concept of lateral access to the epidural space for the removal of herniated disc fragments readily accepted, or did it meet with some resistance?
Following my first publication in the peer-reviewed journal Clinical Orthopedic and Related Research, which was entitled Percutaneous Lateral Discectomy, many physicians in the United States and Europe become interested in my concept of the lateral axis. I was invited to many European countries in Asia, China, and lectured about this procedure, how it is performed. Certainly the acceptance of the procedure, but the CCOT accepted our technique, and we become a member of the CCOT, and so we formed the Society of International Society for Minimal Intervention and Spinal Surgery, and it became a branch of the surgery in CCOT and their affiliates. And also I was privileged to receive awards, recognition by many surgeons in the United States and Europe. However, saying that, I should mention that certain people criticized the procedure, and they were concerned about the size of the tube that we were using, and they thought it may damage the nerve roots and cause problems. However, with development of the anatomy and teaching of the techniques, this fear gradually disappeared.
Okay. What are the advantages of minimally invasive spinal surgery and the lateral access to the disc herniation?
I think we should mention first that the traditional technique for making a midline large incision requires a lot of dissection of the normal anatomy. The muscles are removed from the bone attachment, they are retracted to the sides, bleedings of the muscles, bleeding of the spinal canal, the nerve roots are controlled by coagulations, and all these procedures has potentially causing problem for patients. The minimally invasive techniques through a lateral approach does not require cutting the muscles. The technique requires inserting a hollow tube, which we call it cannula, into the herniation site and remove the herniation under direct vision through the endoscope. So cutting and destruction of the tissue is greatly minimized. As I mentioned, the bleeding of the structures in the spinal canal and around the nerve root usually is all controlled by coagulation, and this itself can cause stasis, or the veins that they drain the blood from the area are closed up. So when the patient began to exercise and began to move, the nerve began to swell because the blood cannot get out. And the swelling of the nerve root and inflammation of the nerve root can cause problem. Also, scar tissue formation around the nerve root and the dural sac can obstruct the blood flow in the nerve and would be also responsible for some of the patient's problem. Another issue that we should discuss is the fact that the nerve roots and the dural sac are not stationary. They are not the fixed structures. They move with our breathing. They move when we bend forward and backward or when we walk. So they can accommodate their positions with our movement. When those structures are damaged by traction during the surgery or massive scar formation around the dural sac and the nerve roots, the mobility of those structures is altered, and it can produce pain later on when the patient becomes active.
You have lectured and published on several techniques that can be used for minimally invasive spinal surgery. Would you expand on which approach is the most practical?
Yes, I think most commonly used procedure for removal of disc is through one portal, uniportal. And with the events and development of unilateral biportal approach, means we put two tubes from the same side of the patient, and later on, development of the oval cannula. It's the oval shape cannula, which allowed insertion of the instrument for removal of the disc, and insertion of the endoscope. We were doing most of the discectomy procedures through a single portal. Of course, I use the two portal for demonstration sometime during our symposiums to show the audience that there was no major danger in doing biportal approach, and I use biportal approach for fusion, stabilization of the segments of the spine. Otherwise, we always use uniportal approach.
Thank you so much, Dr. Kambin.